Good evening. Welcome to the current Advancement in Intervention Cardiology Conclave Series 1. I am Dr. Binayak Deb. I'll be moderating this show. And we have with us three very eminent cardiologists, the interventional cardiologists. We have Dr. Rana Sarajit Roy, we have Dr. Sonali Sharkar, and Dr. Amshad Alam. So I'll give the introductions before they start their cases. And we are in the beginning of the festive season. Durga Puja is around the corner. So this is a good time for us to start our program, which we will be continuing after the pujas as well. So let me welcome our first speaker, Dr. Rana Sarajit Roy. He is MRCP DNB consultant interventional cardiologist at Columbia Asia Hospital, Kolkata. And I personally know him and is doing very good work at that hospital. And let me invite him for his first case presentation. So Prashanjit will be actually presenting the slides and Dr. Rana will be speaking on them. Over to you, Dr. Rana.
Thank you, sir. Good evening, my colleagues and Vinay, sir. Thank you for giving me this opportunity to present one of the cases we have done recently. Actually, sir, a small correction. My name is Dr. Rana Sarajit.
Yeah, Rana Sarajit Singh. It was mentioned here at Roy. Yeah, my apologies. Yeah.
No, sir, no problem. It is just a typing mistake, probably. So I'll try to be as brief as possible and not bore you all with a lot of talk. This was a case we had done a couple of months back. The basic, can you go to the next slide, please? Yes. The basic presentation was a 72-year-old gentleman. He was a male patient. He was diabetic, known for around 15 to 20 years, and also hypertensive. The basic presentation of the patient was acute shortness of breath, which was the patient was orthopnic and it was class 4 shortness of breath, and the patient got admitted under pulmonologist. Now, a routine investigation showed raised cardiac enzymes and the VF was around 30 to 35%. So we were referred to the cardiology department, and just for the basics, the patient was a diabetic for around 15 years. He was CKD4, but then dialysis was not initiated. At presentation, the patient was almost oligoanuric and the creatinine was around 4.5. The patient was in heart failure, acute decompensation, reduced PF, and having recurrent episodes of non-sustained BP in the first 24 hours of hospital stay. Along with that, the patient was anemic. The hemoglobin was around 6 to 7 grams, and the patient had a stool occult blood positive and active passage of malignant. The previous one, please. I need to say some basics. आगे slide please. After a lot of discussions with the companions, the patient was, because no one was intervening with the gastro part because they were saying the patient was not hemodynamically stable and not apt for any endoscopic investigations. A lot of discussion went into it with the companion and the patient himself, and the patient was taken up for angiography, in which we saw that the patient had a critical double vessel disease, including left main disease. The left main disease was around a 50% regular plaque throughout the course of the left main. The angiography was done on day 1, and there was a 80% plaque at mid MAB and 80% osteoproximal plaque also. Then we again went to discussion that intervention as fast as possible, but with some preparations need to be made before the intervention is done, because the patient will be requiring some amount of dye and other supportive measures, for which what we had done was we had first initiated dialysis because the patient is already oligoanuric. Dialysis was done on day 1 and after the angio, and on day 2 we had taken up with the angioplasty phase. Now we can go to the next slide. Plate, hold. If we can appreciate here, the LED had a plaque in the proximal the posterior segment and the proximal mid segment. And there was another plaque in the L6. The views are not clear here, but this is after wiring. We have to do the review guide cat with a 50% almost tubular plaque in the left main. And is the video clear to everyone?
Yes, it is clear.
Clear to everyone. This was after the wiring of the L6 and the LED. The next slide, please. Now, our initial strategy was after the angiography was done. Our strategy was we will put a stent in the proximal LED, and then we will complete the L6. And as because in the angiographic views, the ostia of the L6 was showing around 50 to 60% plaque. So our plan was to finish the distal vessels first, and then go for a bifurcation stenting of the left main and the L6. The next slide. So the LAP job was done, pre-validation, stent deployment. If you can see the videos here. The next slide, please. Now, after deployment of the first stent, we did our first OCT run, and the OCT showed that the lumen of the L6 was clear. But during the OCT run, the patient landed up in cardiac arrest. CPR was started, adjoining medications started, and then we had to be fast and we had to hurry to bring out hemodynamic stability. And we also thought that as because the L6 ostia was not majorly diseased, we will keep the things simple. And what we'll try is to do a distal L6 stenting first, and then just put a stent across the left vein through to the LA. The next slide, please. The next slide. And you can play this. Here you can see a run. It's grossly diseased. Fibrofatty plaque, some amount of calcium is seen. This was the point the patient landed up in cardiac arrest. So what we were informed or what we saw is that the ostia of the L6 is clear. The next slide. For please. Next slide is audible. The video आगे चलेगा. That's just for it. This will be first time. For it. So now we have changed our strategy. This was the left dominant circulation. So initially we had planned that we will do a distal bifurcation stenting over the OM and the L6, but because of the hemodynamic instability, the patient's BP was around 90 systolic with inotropic support. We just pre-dilated the main OM region and we deployed a stent there. The next slide, please. The NC of the L6 stent is not seen here, but then this was the LAD2 left main stenting, which was done. The next slide. The OCT run was done again. What we saw, the overlap zone was very well appositioned with the good apposition with the pull it up. Is all the NC that we did. The next one. The next slide, please. Here we can see the end result. There was a pinching of the main LCX that is going off POM, but then as because there was TV3 flow, our initial plan was to do a DEV in this, if we could have done, but then the BP was on the lower side, the patient was a bit tachypneic, so we had the bicep support on, but then we thought that the all flows are very distilling in all the vessels, and that's why we just went ahead with this one. After next, the OCT done. Yes, this was the final OCT run that was done. You can see the cell deposition is quite well. After this, the patient was around 24 hours in inotropic support in the ICU, but then he did well. We did a dialysis the next day. The patient needed 2-3 more dialysis during his stay in the hospital, and now the patient is doing quite well. If you can appreciate, the unit really came out very well. The application is quite good. That's it. I think this is the last slide. एक और का किसी नहीं होना है, but next का देखाना क्या है? Harmony. This is the last slide, I guess. Thank you.
Okay, Dr. Rana, if you could sum up the case in 2 or 3 minutes, and then we'll go for the discussion.
Yes. So the take-home points or the learning points in this case was that first the extreme hemodynamic instability of the patients and on-table asystole resuscitation, and how we had to decide fast of what will be the best and the easiest and the simplest way out, so that we can have adequate distal blood flow with hemodynamic stability, and so that at least the major chunk of the myocardium stays perfused. The challenges were, as we have already discussed, a lot of comorbidities. Earlier we had planned that the DAPT we will give it for a smaller duration and then take off early because of the unknown cause of the upper GI bleed. And with that, the main point here that we have to discuss is that our initial plan of the LMC, LAB, and the L6 bifurcation stenting, which we had decided on the angiographic views. But then when we saw the OCT runs and the L6 osteo was clear, then we could make that thing more simple by just doing the L6 separate, keeping the L6 osteo free, and just putting the stent over the left into the LAB, and with that the complexity of the bifurcation stenting in such a complex and highly comorbid case was avoided. So OCT helped us with that.
Yeah, I think this was a wonderful case. I'll put my own comments. I would request, we have 2 panelists here, obviously the other 2 speakers, Dr. Sonali Sharkar and Dr. Shamshed Alam. They will be actually commenting on your cases. So I invite Dr. Sonali Sarkar to first give her comments on this particular case. Over to you, Dr. Sarkar. Okay, Dr. Alam, if you have seen the case, could you please pass your comments? Shubhabrata?
Are we online?
Shubhabrata?
Yes, sir.
Can you ask Dr. Sarkar to unmute? Yeah, Dr. Sarkar, if you have seen the
Yeah.
case, could you pass your first comments on this very well done case, I would say, a very complex PCI.
Very
So
complex
your
case.
comments, please. Yeah.
It's a very well done and complex case, sir. But sir, I was actually this thing having some connectivity issues. So
Okay. So I would ask Dr. Alam maybe to give his comments on this case. Dr. Alam?
Yeah, actually, whenever we use OCT, I will say that we are more quite comfortable when we compare it with IVUS. So definitely it gives an edge in your decision making.
Yeah. So I think there are a few things which we can discuss in this case. First of all, it's a very complex case. We are in a acute coronary syndrome situation in a patient of AKT, acute renal failure on CKD, and we have got kind of left main lesions going into the ostium of LCX, and also situation where a bifurcation stenting would be required. May I ask Dr. Rana, did you consider of intra-aortic balloon pump support in this particular case?
No, sir. Actually, we weren't anticipating that chance of hemodynamic compromise might arise. But then we had actually done a lot of observations that he was maintaining his vitals, and he was maintaining BP of inotropes, and his biochemical parameters were more or so acceptable. So we later we thought that if we would have kept the IODP or impella maybe in the background or background support would have been better. But then actually God save our day that we could resuscitate him fast and did the procedure fast. But yes, definitely an IODP or some assist devices would have definitely given a better edge for this patient.
The reason I'm telling you this is because if you have a depressed pelvis function, if somebody goes into assistant in this kind of situation, it is very difficult for these people to come back. So fortunately, you could manage. The resuscitation was successful. The other thing is, did you talk to your cardiac surgeons regarding this case, or what is your procedure in your cath lab?
So actually, in Manipal, we don't have a CTDS backup. But then, yes, we took our time. We showed the CDs to a cardiothoracic surgeon in Apollo hospitals. We discussed the case, but then he was of the thought that because the patient is very critical at that point, having a lot of comorbidities, so he felt that at least stabilization with the main vessel stenting would be favorable for him rather than taking up for bypass, because the patient was having before that having a lot of episodes of NSVT, and the patient was on BiPAP or Orthopnic. So he said that if the bypass can be an option, we have to ship the patient to an hospital, and then we can proceed with that. But the discussion with the surgeon and the companions were more in the favor that they didn't want a bypass. They were more in the favor of whatever could be done with stenting, so after that discussion, only after a very big discussion with them, we went ahead with this case.
Okay, so I think this point is for a medical legal purpose that the CTVS surgeon people have to be on board also while making the decision. So the next point is that so this was a kind of a provisional stenting approach you took rather than a established bifurcation stent. If you were to do a bifurcation stenting, what would be the technique you would use and what are you comfortable with?
Sir, I generally use Culotte mode. And this, if we had completed the entire case safely, then I would have think two bifurcation stentings were needed. L6 OM and then left main L6.
No, I'm talking about the left main bifurcation. What would you have done? Culotte?
The angle was 90 degrees, so we were thinking of a tapping. But then I think I would have been more comfortable with Culotte.
So because the interesting thing is that the Europeans are actually more into the Culotte technique and the Asians are more into the decay crush. So whatever you are comfortable with, I think you should be very good at a particular technique. Yeah, I would agree that a tap technique would have been also something which you could consider. But I think the important thing is that provisional stenting is something which we always have to keep in mind as the first technique of bifurcation stenting. And in this particular case, I think I totally agree with your the thing which you followed of not going into a bifurcation stenting, because I think even if you didn't have SS1 and all, I think procedurally, I think it is important that you could do the procedure and come out fast out of the thing. And you would have a lot of time later on if you had to kind of do other things later on. So the other question which people might think is or may ask is, why did you do OCT when you had renal failure? But because patient was hemodialyzed, I think you had full control. Otherwise, in this scenario, probably people will talk about IVUS. But as Dr. Alam mentioned, that OCT gives an edge over IVUS in particular areas, particularly here. And so what were the sizes of the stents which you put in left main and in the LAD, the distal mid LAD?
Sir, the mid LAD was 324, I guess, and the left main LAD was around 3.524 because the luminal area was less than 4 of the left main OCT wise. So we chose a 3.5 stent there and not a 4 stent.
And did you go up to 4 then with the post dilatation?
Post dilatation, we took a 3.5 NC, but then we went up to 22 in the left main.
Okay, so that probably went up to 4. Yeah. So how is the patient doing after all this?
It is quite well. 2 months have passed by. The patient has come for 2 follow-ups. The EF has not increased, but the patient has almost no symptoms of any shortness of breath or chest pain right now. The patient got 2-3 dialysis in the hospital. Then the patient left, went home. After around 15-20 days, again had an episode of AKI when physiognomic encephalopathy came back, and now he's off dialysis. What we had last week.
Okay. The other issue here is that you mentioned about the GI hemorrhage in this patient. So what kind of DAPT regimen did you pursue with this patient?
Initially, we had thought that we will give aspirin, but then after the discussion with the gastroenterologist, we said that it's possible only to keep it ticagrelor. So presently, he's on Brilinta 90 twice a week. Presently, only.
That is one important area which you need to keep in mind, and how long, because we have 3 stents now, so how long he needs to be on a DAPT regimen and all that needs to be looked into.
Because still, because in the last visit also, we did the repeat OBT for 3 days, which came out to be negative. Hemoglobin is hanging around 7 or 8 grams, I'm not sure. But then the patient doesn't have much clinical symptoms and no active melena or no active occult blood presentation. So that's why we are still continuing with ticagrelor.
Okay, so I think this patient is a good patient for a follow-up, I think, and you should present this case, I think, in a bigger forum if you can. So Shubhobroto can help you to do that. I think this is something which is a wonderful case. So thank you, Dr. Rana, for your wonderful presentation. Shubhobroto, can we move on to Dr. Sarkar now?
Yes, sir. we can move on to the.
Okay, can you,
Sandeep, can you share your
share her screen, do this screen sharing, please? Okay, so let me just introduce Dr. Shonali Sharka. She's MD, DM, Senior Interventional Cardiologist at Bengal Faith Hospital, Bardhaman. And she's been doing very good work there doing IVUS and OCT guided PCIs. And she just now told me that she's starting to do rotablation there. So basically the full amalgam of interventional cardiology is being done at Bardhaman, I'm sure, and she must be a pioneer there, as far as I know, in Bardhaman. So let's hear from her.
Sir, nothing like that, sir, but very many thanks for the kind introduction.
Yeah.
But
Could you just start your IVUS guided multivessel PCI in the case of severe LV dysfunction? Over to you, Dr. Sharkar.
I've run into some technical glitches because I had a slide, PowerPoint presentation with videos, but apparently that is such a very heavy file that it's crashing again.
It's okay, doesn't matter.
So I have the screenshots there, but not the videos.
Yeah, no issues. Just
we can go over to the next screen.
Yeah.
Next slide. Okay. So we have a 67 years old male, Mr. Noori Alam, who is non-diabetic, non-hypertensive. He presented with chest pain and dyspnea at rest since 2 to 3 days prior to admission. He had a past history of ACS in 2006, which was treated by angioplasty, but all his documents were lost, unfortunately. His ECG showed Q waves in leads 2-3 AVF and an LVBP morphology, and an echo showed an ejection fraction of 28% with a global hypokinesia. This time, the anterior septum and anterior walls were more hypokinetic than the posterior, but the wall thickness was preserved and no apparent scar on echo. Among blood tests, the TROP-T was positive, the eGFR was 69, renal function test and counts were normal. The patient was initially stabilized with dual antiplatelet, low molecular weight heparin, diuretics, and BiPAP support. After stabilization, we went into an angiography with very low volume of dye, keeping in mind his low ejection fraction. So it showed a LMCA ostial significant disease, LAD proximal significant disease. LCX proximal, there was some disease. We actually have written significant, but from the angio itself, we were not sure whether it's significant or not, which was extending into the ostium of major OM. And RCA, there was a stent in proximal RCA, which showed an ISR in mid portion. And there was a significant disease in mid and distal RCA. RCA was very big. And later he brought on some papers which showed that in 2006, he had a primary PCI to RCA, which was a bare metal stent of 3 into 30 millimeter. And there was no significant disease in the left system at that time. My next slide will show some still pictures, like this one has ostial left main and LAD is proximal disease. LCX, the ostium, the next picture LCX, there is some disease in the ostium and there is extending into the major OM. And this is another AP cranial view showing again the ostial left main disease. Also, we can see that there is OM is significant and there is some disease in the LAD. Next slide. RCA, there is a stent in the proximal portion of the RCA, which from the papers we came to know is a bare metal stent, 3 into 30 millimeter. And we can see that it's a very large RCA, almost reaching up to the apex. And the RCA, there is also some disease in the mid portion, distals to the stent edge, inside the stent, and also distal RCA. Next slide. So we had a lot of technical considerations. We do not have on-site surgical backup and also a lot of financial constraints. Ideally, we required a mechanical circulatory support and also cutting balloon, keeping in view that we have to work through another stent which has been placed about 8 or 9 years back. And also due to the low ejection fraction, we cannot put in a huge amount of dye. Patient had already presented with acute decompensated heart failure and he required a week of time for stabilization. But fortunately, IVUS was available and I was also happy with the IVUS because we could reduce the dye load. And we planned to do the RCA first. We wanted to go in with an IVUS and look into the mechanism of the ISR, what was the entire length of the lesion, what would be the length of the DES if we use, and ideally what should be the overlap zone, because we already have a metal layer in the RCA. So we didn't want to have 3 metal layers in the RCA. And then the plan for a stage PCI to left main and provisional versus elective strategy to be decided later on. So in IVUS guided PCI to RCA, we came to know that stent malapposition was the mechanism with 70% ISR. But there were significant plaques in distal RCA, and the tightest portion was at distal stent margin, which took a lot of effort for plaque modification. Since we did not have a cutting balloon, like the relatives could not buy anything for us, so we used poor man's cutting balloon. We used 2 run-through floppy wires simultaneously inside the RCA, and we used 2 NC balloons consecutively at high pressures. First 2.5 into 12 at 20 atm, and 3 into 8 millimeter NC, this also at 20 atm. Following this, the IVUS was used to calculate the stent length in such a manner that this I will show in the next slides, that so that we do not have 3 metal layers in the RCA, since we are already planning to put in 2 DES in a RCA which already has 1 BMS. So IVUS length calculation showed us that the distal DES length cannot be more than 38 millimeter. So we used a distal DES of everolimus eluting stent synergy 275 into 38 millimeters, which was used to overlap with the proximal DES of 3 into 38 millimeters. Post dilation, we used a 3 into 10 millimeter NC at 20 to 24 atm, but even then, from the stent boost itself, it was apparent that a portion of the stent had not opened up. So then we had to use an OPN NC, a 3 into 10 millimeter at 28 to 32 atm for optimal stent opening. And I was post stenting showed an MSA of more than 5.5 millimeter square, and we could do the entire RCA procedure with a dye load of about 30 to 40 ml only. In the next slides, I have some views, like this is the proximal stent edge. There is some plaque from the angiography, but it showed that it's not very significant plaque. Like the MSA was is 9.2 millimeter square, so we are happy with that MSA. But in the distal stent edge, there was 80% plaque burden, and the artery was very narrow, a diameter of 2.4 millimeter square. The next slide. And the distal RCA not apparent from angio is there is a very tight plaque, which is giving a diameter of again 2.4 millimeter square. So we could not leave that plaque, and we had to cover it. So IVUS had to plan us to give a distal stent length of 38 millimeter for an ideal overlap zone. The next slide. So these are this thing, NC showing 2.5 into 12 millimeter we used in the distal RCA, and then in the mid RCA, and for the proximal RCA, we used a 3 into 8 millimeter NC at 20 atm for pre-dilation. Next slide. Then we used two stent. The distal one was 275 into 38. And we can see from the second picture that this stent, the distal stent is already distal to the bare metal stent. So we could avoid 3 metal layers here. And the proximal stent was 3 into 38 millimeter, which is overlapped. Next slide. Post dilation was a 3 into 10 millimeter NC at 20 atm, but even then, from the stent boost only, we could see that the stent expansion was not good, so we had to use an OPN NC. For the mid and the proximal portion, the mid we inflated at 28 to 30, and the proximal stent edge we had to inflate about to 32 atm. Next slide. So this is the final result after doing the stenting of the RCA. The next slide. And post stenting, the tightest portion, which was at the distal stent edge with a dia of 2.49, we could expand it to an MSA of more than 5.5 millimeters square, which is adequate for an RCA among us Indians. Like it gave us a diameter of about 3.3 millimeters, so we were happy with the results. We staged the procedure. After 2 days back, we again brought him for a staged PTCA to left main. Here we, before going in with the IVUS catheter, we felt that we should predilate the left main ostium because already his ejection fraction was compromised, and if any further vasospasm or decreased flow in the left system, the patient may not tolerate it. So we pre-dilated before taking the IVUS catheter with a 2.5 12 millimeter NC, the ostium of the left main at 20 atm, followed by, and even from the angiography, it was apparent that there was some dog boning of the NC balloon, even at 20 atm. So we use a higher diameter of NC balloon, 3 into 12 millimeter at 20 atm. Followed by this, we took in the IVUS catheter, both 2 runs we had, LMCA to LAD and left main to LCX. So it showed that the ostial left main had a 74% plaque burden with a diameter of only 2.3 millimeter. So that was the reason why we were not able to get good views even during the angiography, because the Tiger catheter was also not sitting in the left main ostium. The ostium of the left circumflex MLA was more than 5 millimeters square. So that was one of the factors which helped me to decide that better to go in for a provisional approach, and after stenting from left main to LAD, if I lose the LCX, then maybe I will go in for a 2-stent approach. And another factor that was obviously the financial constraint, since this is a state sponsored, so I won't get more than 3 stents, and a 4th stent, if used, has to be bought by the patients, and they were relatives were very, they were very poor, they were unable to afford anything. So we deployed a 3.5 30 millimeter synergy stent at 12 atm, and then what was done with a 4 into 12 millimeter NC at 20 atm. The IVUS run showed adequate MSA and a good stent apposition, but for the left system, we had to use a dye load of 50 ml. The next slide, please. So these are showing the steps like 2.5 12 millimeter. Even at 20 atm, adequate expansion of the balloon was not there. So we used a 3 into 12 millimeter. Then we took in the IVUS catheter into the LAD and then into the LCX. The next slide, please. So the ostial left main 74% plaque burden and diameter was 2.9, and the proximal left main showed a 52% plaque burden. The next slide, please. The distal LAD diameter was 3.46. So since we have to take a stent in any bifurcation PCI according to the distal main vessel diameter, so the diameter of the stent was 3.5, which we had to bring back into the LMCA, and the stent length from the IVUS was 30 millimeter. The next slide, please. Proximal LCX disease, the ostial LCX disease, the MLA, since the MLA was more than 5, we decided to leave the ostium, but LCX in the proximal portion was significant. But unfortunately, we could not do complete revascularization here since the 4th stent was not available for us. And also the RCA was a very big artery and LCX was relatively small, non-dominant. So I risked leaving it back as it is. Next slide, please. And this is a relatively simple 3.5 into 30 osteoproximal left main to LAD deployed. And the next slide. Then followed by the stent flaring and a port with a 4 into 12 millimeter NC at 20 atm, and then a repeat run of the IVUS, which showed some amount of stent under expansion in the zone of the ostium of the LAD and distal left main. So we again took in the 4 millimeter NC and another round of post dilation. The next slide, please. Next slide. So post stenting the ostial left main, the MLA was more than 9.5. And the next slide. And the POC was more than 9. The ostial LAD was more than 8. So according to the rule of like 5, 6, 7, 8, like 5 for the ostial LCX, 6 for the ostial LAD, 7 for the POC, and 8 for the left main. So we were satisfying that criteria. The next slide. So the conclusion was the patient had refused bypass, and we did not have 4 stents. There were a lot of financial constraints, and we ideally required mechanical circulatory support, but could not use it. But fortunately, IVUS was available. We reduced the dye load by using IVUS, using minimal contrast injections, and by using stent boost features. The purpose of IVUS, as far as RCA was concerned, was to determine the mechanism of the ISR, what was the total length of the lesion, what was the plaque characteristic, and what should be the ideal length of the DES, and what should be the overlap zone to avoid 3 metal layers. And for stage PCI to LMCA, the purpose of IVUS was to determine the provisional versus elective approach, although in my case, it was not possible to go for a two stent approach because I could not, the relatives could not afford buying a 4th stent. Also, ideally, what should be the approach to using IVUS in LMCA? Stent length and optimization of result. Also, there is long-term survival benefit of bypass for patients with heart failure with reduced ejection fraction, but only 10% of these patients undergo CABG. And optimal PCI outcomes are achieved by appropriate patient and lesion selection. These results can be optimized using intracoronary physiology, imaging, mechanical circulatory support devices, plaque modification for highly calcified lesions using thinner strut DES, and improved approach to bifurcation lesions. Thank you.
Thank you, Dr. Sharkar, for this very difficult case, I would say. Let me ask Dr. Alam and Dr. Rana to make their comments, and then I'll come in. Dr. Rana, if you could give your comment from this case.
Very good case. We in India have this very thing of financial constraints everywhere. But,
Yeah.
especially all the government aided cases in which the hardware usage has to be very limited and restricted.
Yeah, very limited hardware and without on-site surgical backup. So it becomes you have to plan very judiciously. Otherwise, the patient deteriorates and we land in a soup. Then.
Another thing, sir, if you can comment on this, that because there was a stent restraint, could we have done a distal RCA only, and the proximal we could have done a DV and used that stent in L6? Is that a possibility?
I think because it was a bare metal stent, and this was done in 2006, if I'm not mistaken. So that's about 17 years ago. So probably could get away with another drug-eluting stent. But I must say something, Dr. Sharkar, because you were in a situation where you had financial constraints. I think it's for all of us. I think we should negotiate with the hospitals that, in specific cases, there should be some kind of areas where you can obtain some hardwares like stents and balloons and all. So this is something which is a non-scientific area, but I think if you're dealing with these kind of cases.
Yes, sir. Yeah. You already used the OPN NC balloon, which was negotiated and the hospital provided. So,
well, then you have your second backup, the Abbott people. They can give you another stent. They're always very friendly with us on that issue.
Be generous enough to give you one stent without any.
They will. I'm sure about it. We have been working with them for the last 3 decades. They're very good people. So, but that apart, I think, can I ask you, Dr. Sharkar, about a couple of things? Why did you not do the left ostium first, left vent ostium first, and decide to do the RCA first? What was the logic behind it?
So the logic was that this patient already has a low ejection fraction. And once I go into the left main, I was feeling that if I go into the left main and had the RCA not been diseased, then RCA would have provided a good support because temporarily the left main would have been closed for inflation and for the stent deployment. So I wanted to keep the RCA first, which was a very large RCA, before doing the left main, so that while doing the left main, if by chance the left main temporarily closes during balloon inflations, the uninterrupted flow in the RCA would help to give support for the left system.
Yeah, that's a fair enough logic. The other thing is that for these kind of people with low ejection fraction, it is very important that we have some kind of a backup therapy support system,
Yes.
at least on hand. Otherwise, if these patients go into any kind of
Yes, sir.
arrhythmias or even
Hemorrhage.
asystole, then we
Absolutely.
might lose the patient. So that is something we
Absolutely.
have to keep in mind.
Absolutely.
So what kind of technique do you use for using, not missing the ostium of the left main while you are stenting it? So what is your kind of technique which you normally use? Do you get
So
my question?
yes,
Not
sir.
missing the ostium.
Not missing the ostium of the left main. Sir, one can be this thing, the floating wire technique, like we keep one wire in the sinus, floating in the sinus, and one wire in the left main to LED, so that it prevents deep intubation of the guide and prevents the stent from going deep into the left main system. Second is the view. We have to choose very carefully, be it an epicranial or give it some amount of LAO tilt, like 10 degrees or something, so that we can clearly see the left main originating from the sinus. And while deploying the stent, it should be midway between the superior and the inferior border, so that we do not leave the roof of the left main uncovered while deploying it.
Yeah, because you have to understand that the left main ostium is not circular, it's elliptical.
Exactly.
So
Exactly.
that is the reason you have to understand that if it is a circular thing, you can always place it perfectly. But if it is elliptical, the roof has to be different than the bottom.
Yeah, roof and
So it's
floor
called
are
a
at
Zabo technique actually. Yeah, the Zabo technique is a very used
Zabo
technique for not missing the left main.
left main.
And it is always better to protrude into the aorta a little bit rather than missing the left main. So
Rather than
if
missing
you
the
have to
left
err
main.
on the side of safety, it's always better to have a little bit of a protrusion. Only problem is that if you protrude too much, you
Too
have
much.
difficulty in engaging and again
It's
rewiring
difficult
the
in.
lesion. That is a problem. Otherwise, I think it's a good technique for not missing ostium.
Not
If you were to do a bifurcation, not a established bifurcation, what is your most used bifurcation technique which you use? Like Dr. Rana said that he is very comfortable with the culotte. So what is your bifurcation go-to technique?
So my first bifurcation go-to technique is provisional.
Okay, that's
But
fine. Now, besides provisional, if it's
besides
established,
provisional, sir, had I got two stents here, I would have started from the L6, like the DK crush. I would have stented the L6 first, and then I would have gone from left main to LED.
okay. So DK crush is something which you are comfortable with, but you are aware that DK crush is a 7-step technique, so it requires a lot of
Yes, sir.
hardware and lot of.
Lots of hardware. Lots of hardware.
So I think
Lots of.
because we are constrained by our finances, it is always also good to have another technique like mini crush and all, which is lesser expensive. So all of us, I think, should be comfortable in at least two techniques where you have no limitations of hardware. You can go for the DK crush, and if you have limitations, then you have another technique. But obviously, in our practice, 70 to 80 and even 90% of cases we do provisional stenting. So that is not an issue. We are really talking about 10% of cases where we have to do something. But DK crush to me is something which is, for a very, very difficult financially. There's so many, if you have to
So
do it
many
properly.
steps and repeatedly wiring
There's
and rewiring.
7 to 8 steps you require. But I'm very pleased that, that your generation of people are actually using so much of imaging, which is a very, very good thing. Because I think in our generations, when we did this PCI, I started in 1987, I think, when we used to do POBA. So we didn't have stents at that that part of time. So from there on, we have moved on to a generation who are actually doing image-guided PCI, which is a very, very good thing. And I think OCI and IVUS, they have their own niches. Do you use any physiology like SFRs? I can ask that to both Dr. Rana, Dr. Alam, and Dr. Sarkar. Do you use that often in your labs?
No, sir, we can't. One of the aspects. Sorry, you can speak, sir. You can speak.
Yeah, Dr. Alam?
Sure.
Yeah.
Yeah, actually, day by day, every year, ABC is going more towards provisional, even in left main. LED diagonal, we have, I think almost we have converted our 95% cases in provisional LED diagonal bifurcation, and left main bifurcation, we have converted more than 50% into provisional. So doing an FFR prior to left main bifurcation is a good thing. And second thing, once you move towards a 70%, 80%, and some plaque prolapse and circumflex ostia, at times it is not that easy to cross that FFR wire because it is so much floppy, and we need to at least prepare the ostia of circumflex. In my view, I will always prefer not to disturb that ostia. If the flow is very good, let the stenosis be 70%. I am not going to disturb it. I will prepare left main. I will prepare that carina more better way, so that in future, if it is required, then I can do a deb easily over there.
Yeah, I think that's perfectly logical what you just said. The other thing, Dr. Sharkar, is about using a cutting balloon for ISR. I think that is something which is a very, very important thing. The poor man's cutting balloon, as you just did it with 2 wires and an NC balloon. But I think the cutting balloon will ensure that your bed preparation is very good. Otherwise, as you just saw that you had a dog boning effect even after the predilatation. And once you put another stent in and the dog boning happens, then it is very, very difficult scenario to get back to. So bed preparations for ISR, where maximum times you have either neointimal hyperplasia or atherosclerosis. Besides that, we don't have anything else. So that is something which needs to be looked into very carefully. So I'm sure that this was a very difficult case in terms of the amount of constraints which you had. I think you had both your hands tied in your back while this angioplasty was performed. So, and I would request you to put this angioplasty up in a bigger forum, national and even international forums. I think you can put this up, because this is a kind of complexity of case which is done through imaging, and imaging here actually bailed you out. If you did not do imaging in this particular case, even in Dr. Rana's case, it will be very difficult for you to size properly the artery. Secondly, whether to make a decision whether you can do a provisional stenting and get out or not. And thirdly, in Dr. Sharkar's case, you would have missed the distal lesion in the RCC as well. So imaging is a must now, I think, for complex PCI. There is no doubt about it. It should be a 1A indication. People sometimes say that, European countries, they don't use imaging that much. But I'm sure that, that is because of their financial problems about insurances and all. But I think in our part of the world, if you have to do anything scientifically, I think imaging is the way to go, whether it's IVUS or OCT. And also, I think, as Dr. Alam mentioned, the physiology part is also very important, whether to make a decision whether not to stent rather than to stent. So whenever you have a decision of thinking that you do not want to stent, I think if you do a physiology, then you can always establish scientifically that you had a reason why you did not stent it. So, because stenting is something which we always know how to do, but not to stent something is the important thing. That's why I think the provisional stenting is more important than the bifurcation stenting techniques which we have. So that is something which we need to keep in mind. So let us move on to our third.
One more thing, sir.
Yeah.
We were talking about the techniques. Which technique we are more using for left-hand bifurcation. So whenever, in my view, whenever we are going for a dedicated bifurcation, we have to keep two separate techniques. Suppose that case of Dr. Sarkar, it was a hemodynamically unstable case. So in these cases, I will prefer doing a mini crush because it takes less time.
Absolutely.
And then I will further do imaging once patient gets stabilized. And even I can wait for 1 or 2 more days. Suppose that if my dye load is going to be high, then I will do the most necessary part and again make the patient come to my lab.
Come back later. Yes, absolutely. So we can start with your case, Dr. Alam. If you are ready with it. So
yes, sir,
let me introduce Dr. Shamshad Alam. He is a good friend of mine and a senior consultant interventional cardiologist at Medanta, Patna, and has been doing wonderful work there. So let us see what is your case when you need to go beyond the recommendations. Life-saving multivessel PCI on mechanical circulatory support in patients with cardiogenic shock and pulmonary edema. Over to you, Dr. Alam.
Yes, sir. Actually, I'm presenting the cases. Actually, technically, these are not so much demanding, but the situations, these are demanding. The time constants which has to be taken in mind when doing these kind of cases, and the planning. Because the problem is that we have to plan it within 5 minutes. What we are going to do, because it's all a non-law kind of thing, because it also about to the patient's life. So I am presenting two cases in cardiogenic shock. At times, it is a recommendation that in cardiogenic shock you need to do culprit vessel PTCM only, and then wait for some time and do a stage procedure to other vessel. But at times, it becomes necessary to do a multi-vessel, because suppose we are not able to get a good flow through the other vessels, and you're already the vessel which you are intervening, it has got infarcted a lot and it is not going to help that much, then obviously you have to give that support from other vessels. So let's start from first case. So we had a 60 years old diabetic male, history of previous subdural hematoma, who was operated 7 years back. He presented to us with a history of chest pain for last 2 days. He was brought to emergency in cardiogenic shock with acute pulmonary edema. New onset left bundle branch block was there in ECG because his previous ECG was available. With metabolic acidosis was there in ABG, echo revealed severe LV dysfunction with an ejection fraction of barely 20%. He was having severe mitral regurgitation. He was having akinesia in both LAD and RC territory too. He was immediately put on dual inotrope support. He was put on NIV support and was shifted to our cath lab immediately. Then a femoral access was taken, a quick angiogram was done, which revealed subtotal occlusion of right coronary artery as well as complete total occlusion of LAD. His left circumflex was doing well, non-significant lesions were over there, and also we can clearly see that there was a calcification in his septal area. So after that, immediately he was put on IABP support, because mechanical circulatory support was a dire requirement in this case, and immediately a Swan's catheter was put in his left pulmonary artery so that we can monitor fluid requirement, his IV fluid requirement as per the pulmonary artery pressure. His PA pressures were very high; it was 65 mm. So it was very helpful in guiding fluid therapy. So the next plan. The revascularization was planned. We had our CTVS backup upfront. In this case, we had an immediate heart team discussion, and the family was involved. And finally, a decision of multi-vessel PTCA was done because there was a lot of confusion that which is an infarct-related artery. With presentation with new onset left bundle branch block, involvement of LAD as a culprit, it was suspected. But both area of right coronary artery and LAD, they were compromised on echocardiogram, and also there was seepage derived from right coronary artery. So immediately a right radial access was taken for PTCA, because the femoral access which we had taken for angiogram, it was used for IAVP insertion, and a cangrelor infusion was started after a bolus dose. And a final loading dose of ticagrelor 180 milligram was given after the procedure. Immediately PTCA to LAD was done, and it was explained to family that this is a short procedure, we will do it quickly, but if his mitral regurgitation will not improve, then he might have to go for surgery or a percutaneous mitral valve repair. So 6 French JL guide catheter was taken, LAD was wired. There was slight difficulty, but we were able to wire it with a whisper wire. Pre-dilatation was done with 2.5 20 NC balloon. A good flow was achieved. There was also a distal tight lesion, but we were not bothered about that distal lesion, because we had to maintain, we had to do something which should maintain flow in LAD. So after getting a good flow in LAD, a 332 mm drug-eluting eluting stent, it was placed. Synergy stent was placed in LAD just after the ostia. It was inflated up till 14. Post-stenting, good TIMI3 flow was done. The LAD perfusion was very good up till the distal segment. And but just after this, even though after a satisfactory stent expansion, patient had cardiac arrest, CPR was done, he had asystole. After that, so immediately he was revived, and the Swan's catheter was removed, and that access was used for placing a temporary pacemaker wire. So after immediately after that, the flow in LAD was rechecked, and it was found that it was flowing well. No flow compromise was there in LAD. So we decided to go further with right coronary artery, because with dual inotrope support and IVP support, we were getting a good pressures. So right coronary artery was hooked with a right 6 French JR guide catheter. Whisper wire was again used. Some difficulty was there, but we wired it successfully. The mid RCA subtotal occlusion, it was pre-dilated with 2.520 balloon. Good distal flow was achieved after pre-dilatation. It was a long lesion, so we plan to use two short stents, because opting for a long 48 stent would have been difficult to do that procedure in quick time. So a 3.5 30 mm drug-eluting stent was used, and it was inflated at 14 atm. We use Orsura stent so that we can pass that stent easily in that segment. Then after mid RCA stenting, the same stent balloon was used to prepare the proximal RCA lesion, and check shot revealed good proximal lesion preparation with a good distal flow. Then a proximal 3.5 into 32 mm drug-eluting stent was deployed in proximal RCA at 16 atm. And post-stenting, there was slow flow in RCA, for which we gave intracoronary adrenaline. Finally, a good distal flow was achieved, and we can easily see that there was a huge PLB branch, which was suggestive of a superdominant RCA. The chronology of events after this procedure, it was like that patient was shifted to CCU on IBP and IV support, heparin infusion with dual inotrope support. Loading with ticagrelor was done, and cangrelor infusion was stopped after 2 hours. Adequate hydration and urine output were monitored alongside infusion of Lasix. The inotrope dose were gradually tapered. Initial serum creatinine, it came out to be 1.6, and it decreased to 1.2, fortunately, on day 3. NIV support was removed on day 2, and he was completely weaned off from IBP support on day 3, and gradually he was tapered off from his noradrenaline support, and adrenaline support was stopped on even in later part of day 1 only. He was able to maintain his saturation room around day 3. Bedside mobilization was done, chest physiotherapy was started, and we re-reviewed echocardiogram. The ejection fraction improved till from 20% to 35%. There was significant improvement in mitral regurgitation, which was initially severe. It decreased to less than moderate, and we were surprised that on day 3, the contractility in RCA territory, it significantly improved as compared to contractility in LAD territory, which was a marker that LAD involvement was a sign of previous atrial MI, and current involvement might be due to right coronary artery. And finally, he was discharged home on day 5. Proper mobilization was done, and he is on regular follow-up. No significant complications, no significant, and no. The good thing is that no repeated heart failure hospitalization has been there. He has been on optimal medical therapy for his low ejection fraction also. So, and this is the second case. We had a 35 years old diabetic male who presented to us with atrial MI, acute decompensated heart failure, cardiogenic shock, severe LV dysfunction was there. He was immediately put on NIV support, high dose inotropes were given, and a quick coronary angiogram was done. This was the angiogram. The right coronary artery, there was a significant in right coronary artery, there was significant lesion. I think my voice is audible because I am facing some technical glitches.
Yeah, you are audible.
No, your voice is
videos
audible,
are
sir.
not moving.
Yeah, my slides are not moving in between.
Yeah.
I will reshare the second case. So in between, we can have a discussion for the first case, because I need to restart my PowerPoint presentation. It was a big presentation, so I think I got hanged.
I think I carry on with the second one, and then we'll finish it. Yeah.
Sure, sir. I think my screen is visible to everyone now.
Yeah, it is visible. Yeah.
So we did a quick angiogram. An angiogram revealed a triple vessel disease. Ostial RCA was significantly involved. And there was 100 near total occlusion of left antidescending artery proximal in the proximal part. There was a critical 99% stenosis in a large circumflex, proximal part of large circumflex. Still, I am facing this technical glitch. Let me solve this. It will take hardly few seconds for me. So after getting an angiogram, we quickly discussed with the family that whether they need to go for an urgent CABG, because that thing was available at that time. Patient was having severe mitral regurgitation in this case also. Actually, still I am facing some technical difficulty.
You can discuss the case, and then we can move on.
Yes.
Yeah.
So in this case, what we did, we put the patient on IVP support. We did an PTCA to LED immediately, and after that, we got a good supply in LED. So this will be a good thing. And then we placed a 333 mm everolimus eluting stent in LED And this was the result of doing a LAD PTC. A distal lesion was there in LAD, but we were not bothered and we were not that much keen in disturbing that lesion at this moment. As the patient was in cardiogenic shock and he was requiring multiple inotrope support. Then we planned that we will tackle that circumflex lesion also, because the LAD area was already infarcted and circumflex was giving a very large area of blood supply. I can show you the circumflex, because due to that technical glitch, the circumflex you people could not have seen. This was the circumflex.
Maybe we can just proceed with the discussion.
Okay, I think for the constraints of time, Dr. Alam, let us discuss the first case. Okay, so Dr. Rana,
Yes, we
could
can
you
discuss
just
it.
summarize what Dr. Alam has just mentioned, and if you have any comments? Alam?
Yes, for the second case, I must say it was quite. Oh, we are discussing the first case first. So for the first
Yeah.
case, it was a diagnostic dilemma that which was the infarct-related artery, but the slow flow in the RCA in the last what we saw, and the later the improvement of the ego in the RCA part suggested that it is primarily the infarct-related artery within RCA. But then, yes, definitely doing such things in an acute state of cardiogenic shock with IVP in place is quite challenging and difficult, and the outcome was quite good for that patient. If I can ask that, how has the MR developed in that patient in the first place, if you are in follow-up with the patient?
Alam?
Yeah, actually, in the first case, the LAD was compromised. The even right coronary artery was compromised. So whenever LAD and RCA both get compromised, there is significant reduction. And as I mentioned at the last, that after stenting right coronary artery, that PLV was very big. It was a super dominant kind of RCA. So that was the reason for involvement of mitral valve apparatus.
So how is the MR after follow-up?
MR, it decreased to less than moderate on day 3 itself.
Okay.
That was acute MR, secondary ischemia.
Yeah, it was an acute MR.
Yeah. Okay,
because
thank you,
on
Dr. Alam.
echocardiogram, we were unable to depict any papillary muscle rupture kind of thing.
Yeah. Usually with inferior walls, actually, sometimes it goes away. But with anterior wall MRs, they don't go away. That is the usual case. When you revascularize RCA, the MRs usually go away if it's the RCA case. But if it's a LAD lesion involving anterior wall, then usually it's a papillary muscle necrosis causing rupture or dysfunction, which will not go away with revascularization. That's usually the scenario. So thank you, Dr. Alam, for your wonderful presentation. And also thanking Dr. Rana and Dr. Sarkar for taking out the valuable time before the puja vacation. So wishing you all a wonderful festive occasion in the coming weeks, and see you again sometime, and thanking Abbott for facilitating this meeting. Thank you all again. Have a good night. Thank you.
This was the circumflex, which I will
Just
show you
go ahead and show it.
in the second case.
Yeah.
Yeah, this was the last circumflex. And PTCA to RCA, we did it after 2 weeks. And the second case, we did LAD and circumflex in same setting on IVP support. Patient was removed from IVP support on day 2 itself. And the improvement in second case, it was very markedly. We were a lot surprised that how that can improve to that much, because the EF it increased from 25% to 45% before discharge. when I took this patient for PTCA to RCA, his EF has increased to 50%. So might
The
be
dramatics
that
happen
the
actually
age.
with the RCA. The RCA revascularization is something which is underestimated because we get a lot of issues with ischemia, but with the LADs, usually the things are not so reversible once the infarct has set in and we are late into it. So I think LAD cardiogenic shock and RCA cardiogenic shock, both are different animals which we are treating basically.
Yes, sir.
So thank you again, all of you, and wish you a very good festive season, and see you again sometimes, maybe in person, in some physical meetings. Okay, all the best.
Thank you.
Okay, sir. Thank you, sir.